Hello, Professor McGill. Thank you very much for speaking to me and for your time. I've been following you for some time, and I'm a big fan. And I've got a long list of questions in front of me. But before we start, do you mind telling us a little bit about yourself and about your career?
Yes. Good day to you, Marek, first of all. And can I say Zladsky?
Czeladski.
Oh, Czeladski. Okay. I've had a few Polish students over the years, and I've been schooled in pronunciation, but I've got it. CZ Czeladski. Okay. Well, I was a professor for over 30 years at the University of Waterloo. And when I started, I only had one question, and that one question was, how does the back work? So we would set up different experiments and from different vantage points, different methodologies to try and understand how the back works. And then that evolved into, well, how does it become injured? What are the pathways to pain? And that took us into many different integrative studies. And then I started a clinic, and it was an experimental clinic. And I said, well, we're going to start with 2-hour appointments when we see our back pain patients. And my colleagues said, you're crazy. What are you going to do for 2 hours? And I said, well, from what I've found out thus far, I don't see how I could spend any less than 2 hours. I need to talk to the person. I need to understand the impediments as to why they failed before. I need to know all about their lives. I need to watch them move to understand their habitual movement patterns. I need to know their learning style. I need to know what makes them more painful and what makes them less painful. And then I need to do physical testing. Pain provocation, and then I have to try and work with the antidote to see if my hypothesis is correct. If this is what the pain generator is, then if I take the load away, I should have less pain immediately. So I had to do all of that. But as we all know, this is modulated by various personality traits and expectations and all the rest. So do you know, after the first year, Marek, I changed the appointment times from 2 hours to 3 hours. And this became...
That's a massive jump.
Yes, but, we still set aside 3 hours to this day for our back pain patients. Now, of course, some are less, but some are even more as well. So there you go. People fly in from all over the world now. I've retired from the university, but we still see patients who are struggling and have failed with the usual clinicians.
So based on your experience and research so far, what is the most common cause of back pain, would you say? Is that to do with the spinal disc and the process of delamination, collagen delamination in the disc?
Well, let me answer that question this way. Pain forms patterns. Now, you know that gymnasts, as a subgroup of athletes, typically, if I said to you, there's a girl with back pain upon extension and she trains gymnastics, I hope you would probably think spondylolisthesis is a good start. That's the pattern. Who gets spondylolisthesis? Young female gymnasts, cricket bowlers, dancers. So that's full range of motion, stress strain reversals on the pars bone, back and forth. So there is a subcategory where I would say, probably, if it was extension intolerance, I wouldn't think discs at all. I would think a fracture, or at least a stress fracture of the pars. Think the next group. Let's take a group of young 20-year-olds doing CrossFit. Now there's your group who would be characterized by very common delamination of the collagen fibers leading to a disc bulge. They do Olympic lifting, they do a lot of mobility. That combination, if they cross the tipping point, would lead to collagen delamination and a disc bulge. But then let's take an Olympic lifter. Where do the great Olympic lifters come from? Poland. Anyway, when we look at that as a subgroup, they don't get disc bulges as a rule. It would be quite rare for an Olympic lifter to get a disc bulge who was a true Olympian, not someone who didn't know how to do it. Of course, they could have all kinds of things. Their backs are quite good. The real Olympic lifters, of course, they have problems with their knees and their shoulders and these kinds of things. But what's happening in China over the last 8 years or so, the Chinese have really adopted an Olympic lifting style of massive extension. And they really default into hard locked back extension and pull from the hips. And you will see a great amount of extension intolerance and real facet irritation among them. So rowers, there would be another group where I would agree with you that what's the rower's disease? Posterior disc bulges. Recreational soccer players. They tend to be more, if they just recreate and play soccer through their lives, they tend to have more of the arthritic spines towards the end of their career. Whereas maybe they have a twin brother who didn't play soccer, they just went running. They were a recreational runner. They didn't get the arthritis to the same degrees in their spine. So there's the answer to your question. What causes most back pain? If you give me a pattern, we'll start subcategorizing patterns because we're laying bets now. What is most probable? And when we hear those stories from the patients, we'll say, I'm going to make a bet that yes, your symptoms match a delamination, an open fissure in the collagen, and a disc bulge that grows when you sit, shrinks when you go for a walk, and those are the two activities that you say make your back worse and better, respectively. But not for the next pattern. So there you go with an answer.
And Stu, with patients with long-standing back pain, do they stand a very good chance of recovery as well and getting better?
Sorry,
is it more likely that they're going to need a surgery at some point?
Okay, well, that's two questions, but I would say most have a very good chance for recovery. Now, that's going to be categorical once we get to the pain mechanism, of course. But let me tell a little bit, or create a little bit of an essay to answer that question. First of all, I can prove it that most will get better because over the life of the clinic at the university, we followed up with every patient. So we knew who got better and who didn't. We followed up with every single one of them, not one was missing. And before I give you the statistics, I'm going to give context. And that was that in order to come to the university back pain clinic, you had to have failed about 10 different previous clinical attempts. So they've been to the chiro, the osteo, the physical therapist, they've seen the surgeon, you know, they've really run the gamut of back pain treatment attempts. So we got the failures. So among those failures, I can tell you that if we subcategorize them based on intolerance, these are the statistics. So I'm going to read some of these. If they got pain from flexing, so if they sat at their computer or drove their car or picked boxes off the ground, for example, if that was their pain trigger, 50% of them got better after that 3-hour visit in a 2-year follow-up, 50%. to the point where they said they had no issues with their back. Now, if we categorized them as extension intolerant, so standing extension caused their pain, or any kind of extension movement, particularly with a bit of load, 80% of those after 2 years said, after that 3-hour assessment and being told what to do, we have now no issues that are substantial and remaining. If they were motion intolerant, so both flexion and extension, in other words, you do a pelvic tilt back and forth, and if that triggers your pain, 75% of them said they were fine after seeing us. Sorry, 80% if they were motion intolerant. Now let's look at the loads. If they were compression intolerant, so if we sat them on a stool and I said, pull up with each hand 15 kilos per side, and does that trigger your pain? If the answer is yes and the spine is neutral, only 33% of them said, no, I was able to deal with my pain. So compression intolerance is tough. If you can't bear compression, that's a much longer process. Typically and statistically to get better. Now, if we subcategorized the patients by tissues, so if we did our assessment, we said, your pain is primarily discogenic from the discs. 50% will say they did well with our approaches, that they only 1 3-hour time now. And remember, these are all failures. But if we determined that the primary pain generator was from the facet joints primarily, and secondary the disc, they rose to 78%. So a much better success rate. Now, if we look at all the various tests that we perform and then say, which of those tests are predictive of who's going to get better? They didn't. So no test scored better than 50%, but the very best test was the prone instability test. It had about a 50%, if that triggered your pain, half of the people would have done well with that 1 3-hour assessment. But here's probably the most interesting statistic. Of all of those people who showed up and were told, you've seen all of these experts now, and the only remaining option for you is surgery, because I think that was your second question. If surgery is your last option, and you were told that, 95% of them avoided surgery, and they were glad they did. So that's basically following the protocol in my back mechanic book, which is now in Polish, by the way. I forget the exact name. It's just outside if you need it. But anyway, so I can stand by those numbers because we measured them from follow-up.
So I'm really interested because I'm following your assessment process, and that takes between 2-3 hours. Do you always find a cause of pain? I know you don't agree with the concept of non-specificity when it comes to the back pain. So there's always a cause, you think?
Yes, I'm very convinced of that. So let me give a little bit of context for that, and it'll help form a little bit of an essay on this whole issue. So the issue is pain random? Could you imagine going to the doctor and say, I've got non-specific head pain, or I've got non-specific knee pain? It's not tolerated and it's not heard of. They get an assessment of their head or their knee or the emotional states around those pains, and they determine what are all the factors that are creating this pain, because pain isn't normal. There's something driving it. Now, primarily, most of the time there's a mechanical basis to it, but not always. I understand that, but it still means there's a cause for whatever that cause is. So this really has to do with the randomness of pain, which I don't think exists. So we perform, as I described a little bit, a very extensive interview, and we're looking for patterns. And then we ask them, what causes the pain to get worse and what causes the pain to get better? Almost every person can name an activity. When I drive a car, my right toe goes numb and I get back pain. Good. Now look up. Oh, that makes it worse. Why? They've got an underhook on the nerve root, so it causes the spinal cord to drift down. The reason that this non-specific back pain descriptor survives is because the assessment skills of most clinicians is not good. They are not masters. So if they can give a diagnosis of non-specific back pain or lumbago, or you've got degenerative disc disease, or worse, you're magnifying your pain, it lets them off the hook. It makes them feel good, and no one holds them accountable in the system for being not a master and dismissing that patient. So this is why I'm so against this. I say, if you can't find the pain, you go back and find it. You try again, because you will find it with competency. So, you know, it's not that I'm against cognitive behavioral therapy or any of these other approaches. I'm against cognitive behavioral therapy if the clinician does not do an assessment. So there are clinicians now, particularly in the NHS in the UK, where a back pain patient comes in and they don't get a thorough assessment, and they're saying, well, we'll teach you how to live with your pain. Because I've had some of these patients. I had a police officer from the UK who started to cry, broke down, a very tough man. He was so emotionally broken by the NHS because some therapist said, they gave him a pamphlet, How to Learn to Live with Your Back Pain. They never assessed him. It was a crime. When we asked him to sit, very simply, sat in a chair, pull up. No, that doesn't cause pain. Now slouch. Oh yeah, there's my back pain. It became so simple. And I said, okay, don't sit like that. Sit like this. Oh, my pain is gone. Now, here's how you brush your teeth. How do you brush your teeth? Oh, like this. All right, that causes pain. Good. You know how to play cricket. You're from the UK. Go in the outfield, put your hands on your knees, shape your back, lift your tail. Oh, my pain is gone. Good. That's how you brush your teeth, sir. And he broke down crying, saying, how come no one has ever told me this before? And he was back to work in no time. So there you go. I think it exists because I blame it on clinicians.
I have to tell you, Stu, that loads of my patients, they've got physically demanding work and they come to me with back pain. I'm talking about cleaners, about factory workers, also drivers, and people spend long hours doing their job and then doing exercises, rehab exercises afterwards is quite a challenge. And I know those exercises won't be done. So non-compliance is an issue, I find. And how would you approach that? And what would be the best way to maybe for those patients to go about rehab at home?
Okay, well, I can answer that two ways. One, I'm going to give you some examples where we've measured this. And the other thing I have to say is it doesn't make sense to give people more exercises when they're already doing demanding work. So I think that is a non-rational approach. So here is an approach that we've trialed in several different heavy industries, and I'm going to give you some statistics now about its effectiveness. First of all, when we measured men who chromed car bumpers at Chrysler, so they were building Chrysler cars and the car bumpers weighed almost 40 kilo. and they lifted these all day long. So a very demanding job. All of the men were doing the same job. So the ergonomics of the situation, it was all the same. But less than half of them had back pain where they would lose time from work every year. More than half never had a day lost due to back pain. What was the difference between the workers who had pain and those who didn't? Do you think the workers who had pain were stronger? Or do you think they were weaker? The ones who had pain?
Stronger.
Yes, they were. Do you think doing more strengthening exercises would help them? That wasn't their problem. They were already stronger. The problem was their movement patterns. The stronger ones would get tired. So not only were they stronger, but they had less endurance. So they would pick up the car bumpers with their hips and move them. Very good movement in terms of avoiding stress concentrations in their back. But those who had back pain were stronger. They would lift for a little bit and then they got tired. And then they stopped using their hips and they started to use their backs. And they would then start lifting the car bumpers like this. But the weaker, more endurable workers did not. So that's my first bit of evidence. Then a colleague of mine, Bob Norman, was in a team measuring workers at General Motors. And those workers, again, all doing the same car assembly jobs. Those ones who moved more poorly had higher shear loads in their back. And he made statistical cut points based on load exposure because of the way the workers chose to move as to whether or not they were going to be a member of the back pain disabled group or the survivor group. Anyway, there's been quite a number of these studies. Bill Maris has done quite a number of studies as well, showing that it's the way that people move. Now, ergonomics here is not unimportant either. If you're designing the work, if you're an industrial engineer or a therapist consulting to help the company, if the worker doesn't need to place boxes on the floor, don't. Picking a box off the floor is much more stress and increases the incidence of occupational back pain than placing the box on a table about hip height. So it's a combination of ergonomics and movement training. So have we trialed this? And here's proof. Yes. At Goodyear Tire Manufacturing, they make tires for cars. There was a plant here where we put in a program with an occupational health nurse and a kinesiologist who we call the job coach. They went around to the different jobs looking for ergonomic opportunities, job design, but they also trained the workers in basic patterns of lift, squat, lunge, push, and pull in the spine conserving way that I just showed you. You know, with the cricket bowler pulling the hips through and these kinds of coaching cues. That cost $250,000. So the salary of the job coach plus the nurse and whatnot cost the company $250,000. The next year, we compared the direct payouts paid for compensation on back pain. They saved $1.3 million. The payback was 5 times. So if people want to argue with me that these things don't work, in fact, they do, but I don't think doing exercise is the way for a worker who is already over-exercised in their job. It's a combination of ergonomics and movement training. And if they are, it isn't strength training. It's going to be movement patterning and endurance training. And that's been shown in some Danish studies, etc. So there's a little bit of an essay on the start of that. But I will say, Merrick, if you have an individual worker comes into your clinic now, and that worker doesn't have back pain, but they're doing a demanding job, how effective are you in coaching a person who's never had pain? How do you motivate them? And I will admit, it's very hard to motivate the unpained and the uninjured. They only listen to you when they've got pain.
Yeah.
So from an individual point of view, I appreciate the challenge. But from a company-wide point of view, I don't buy this idea that you just give up and prevention isn't effective. We've proved several times now by saving substantial amounts of compensation payouts on grand scheme.
You mentioned a police officer from the UK coming to see you with back pain and having had an unsuccessful treatment in the UK from the NHS. And you said that his psychological well-being was very poor. And I wonder, do you see in patients with very poor psychological well-being that the recovery rate is not as good, or they don't recover as quickly? So in other words, is psychological well-being essential to recover quickly from back pain?
It's a fabulous question, and I could argue that both ways. With that police officer, there was no question that he was a tortured man brought down to the state of tears because of his experience with the NHS, and it was psychological abuse. It was so quick. As soon as he learned he was in control of his back pain through proper coaching, the psychological dissonance disappeared immediately. He got his strength back, and he said, why hasn't anyone told me before that I'm in control? I now see that. And he was away. He got his full psychological constitution back. He started to sleep well. And so there's an example of psychological situation being caused by poor clinic, and he had an immediate turnaround. But now we have another person who they are in a situation, they're in an abusive relationship at home, they can't do an exercise on the floor because they'll be abused by a spouse. They have a job that they hate, they don't want to get better to go back to that job. I understand all of this, but it doesn't matter if we can't address the mechanism of their pain, which is they hate that job. I get it. But it's still a mechanism. There's still a reason. It just happens to be a mismatch of jobs. So what can we do as clinicians to recognize that and get the person going to the right source of help? Maybe it's job counseling. That is very part of their getting their back pain settled. And we'll do this. You know, again, I keep getting misinterpreted. Oh, McGill is the mechanical guy who ignores the psychosocial. That is so unfair. They've never studied with us. They've never worked with us with patients. We will do anything to address the reasons that are conspiring together, causing that person pain.
Yeah. And what do you think about that concept of central sensitization and the upregulation of the nervous system in back pain patients, and how important it is in therapy?
Well, it can be of no importance, or it can be of incredible importance. Once again, the answer is it depends. So consider you bang your toe against a chair or something, you stub your toe, it hurts. The next day, you do it again. It hurts even more. And then on the third day, all you do is lightly touch your toe with your finger and you're about to scream. Or have you ever bitten your lip? You bite your lip and oh, that hurt. And then darn, it swells up and you bite it again. And oh, so we get it. We get central sensitization. So how do you wind it down? You teach the person to stop stubbing their toe. So if flexion is their pain trigger, when they get off the toilet, spread the knees, get the feet underneath them, be a peacock, sniff a little bit of air, move forward through the hips and pull the hips through. For the first time, they didn't stub their back. we gave them a movement hack to start to wind down the central sensitization. When they tie their shoe, we will teach them, sniff a little air, move your foot into, or take your hips down to the target and tie your shoe. For the first time, they didn't stub their back yet again. So we give them hacks around the variable that all day long picks the scab. Stop it. Let the scab heal, and central sensitization slowly winds its way down. Now they can dance and free up and have lots of fun and movement once again. And that's really how we would bring back an athlete, say, where their chronic variable that keeps hammering away at the central sensitization because of their sport. We use spine hygiene throughout the day to keep winding down the central sensitization, opening up the training capacity, and then they get their mojo back and they're right back to a normal neurology now, and we can start training the necessary variables for them to be good at that sport, or to be good at that job, or to pick their grandchildren off the ground, or whatever it is. So there's a spectrum of responses. Once again, it depends, and that's why clinicians will never be replaced by computers.
Excellent.
It's a real expertise, for sure.
Stu, what's your approach towards hands-on techniques? I'm talking about manual therapy, osteopathy, therapeutic massage. Do they have those techniques on those types of therapy, ways of therapy? Do they have a place in back pain management?
What's the answer? It's 2 words.
I would say yes.
I would say it depends.
Okay.
Yes. So I was leading you. Here's how I would answer that question. Let's take a patient who has pain triggers from micro movements. This is a wonderful model from Dynamic Disc Designs. You're probably familiar with this company. They're fabulous models. So this L3 is a normal disc. L5 is a normal disc. But L4 has lost a little bit of stiffness. So maybe there was an end plate fracture or a delaminated collagen in the annulus or whatever. But I'm now going to apply a torque to this. So they might be rolling over in bed, as an example. Do you see that the majority of the motion takes place at the joint that has lost stiffness? Do you see that?
Yeah.
So there's an example of a unstable joint. The one above and the one below are normal, but that's where all the micro movement occurs. Now look at the facet joints on the back. Yet again, it is the joint where the disc has lost stiffness, where the facets are now bearing the high stress concentrations of the movement and extreme ranges of motions. So if that person went to a soft tissue person whose expertise was to create mobility, I would say no, do not massage that. Let it be, let it gain normal stiffness again. But the next person comes in, and if I may, I'm just going to get, is it this? Yes. Here's this model. Just on my wall, I have about 40 of these different models, all mimicking different mechanisms of pain. So these are all cast from real people. Now, this person is going to extend. So they're going to extend, and we see good motion there, but they extend a little bit more. Now I'm going to release. Did you see this joint released and this joint did not? The facets are stuck. Now I have to, there, I just popped it off. So again, it depends. This joint is stiff. That joint, I might ask one of my soft tissue gurus, could you gently work a little bit more motion? Or we have a discogenic patient, lay prone on a table. Breathe a natural lordosis back into your back. Oops, we've got one intalgic segment. It's not releasing. Could you take your beautiful hands? No, I don't. I'm not a trained mechanical clinician, manual clinician. But would you now use your beautiful hands and work that stress concentration out of that joint for me? And then the patient says, ah, for the first time I can move without pain. I do a lot of work with high performance athletes. Do you know of a medalist Olympic sprinter who doesn't have extensive soft tissue work done? They won't win. I don't know of a single one where they don't benefit from stripping and separating tissues, just tuning the elasticity for perfect storage and recovery of elastic energy. You know, the things I've learned of the connection of the psoas muscle and how I can pull on the psoas muscle by how I position my hand overhead. It changes but that is a fascial connection all the way through. And if that isn't addressed, I've got non-optimal function. So again, I know there's people on the internet who say, oh, manual therapy is non-justifiable, and they'll use even worse language than that. My answer to them is, how come I've never seen them or their athletes on the podium at the Olympics? The answer is you don't. So do you see how sometimes it's an art. It's an art and a science, manual therapy. And as you know, there are people who are incredibly skilled, and there are those who just talk about it, but they're not. But I can name some names. If you go to the US, to the Central Institute for Human Performance, and you can feel the hands of Dr. Clayton Skaggs and how he tunes the body, it's marvelous. I benefited from him. I was supposed to have hip replacement when I was in my 40s. And I would see him, I would fly to St. Louis from Canada, and about every 3 months, he would take the pain out of my hip, tune the tissues. And then I would go and see another person who was all yak, 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 yak on the internet, and they were brutal. They would cause me pain. So, you know, I think of, do you know the book called Stretch to Win by Anne Frederick?
No.
It's a wonderful book, and Anne Frederick is a guru. And when you go there, you will see the elite of the world performers as she magically tunes the body. Larry Bell, if you are a sprinter, chances are you will have seen Larry Bell, who tunes the elasticity in the foot, the ankle, the various chains, excuse me, through the body. And his son, Dr. Spencer Bell, has the gift of the hand as well. So that's my my answer. Of course, it depends, but there are some absolute masters of soft tissue work, and there are those that stir up a hornet's nest.
Yeah, yeah. MRIs and X-rays, and how important are they in your role in treating patients with back pain? Because I find patients very often maybe overemphasize the role of radiological findings. They're worried about structural damage causing pain, and I know there is the correlation between the structural damage and the pain is very minimal or small, but it's just patients are very often worried what MRI is going to show, and they think the more damage, the more pain they're going to have, and because of that damage in the spine. What do you think about radiological findings, and how important are they?
Okay, just give me 10 seconds here, and I'm just going to get a book that I wrote with Brian Carroll, who he owned a couple of world records in squatting load. So my answer is 2 words yet again. What's the answer?
It depends.
It depends. So you're absolutely correct. There are some people who obsess over the MRI description, but now we have a problem. The radiologist never assessed the person when they wrote that. So it's not that MRIs are unhelpful. If the person has back pain and they're going to see their first clinician, I don't think they should bother with an MRI. But by the time they come to BackFit Pro and they've failed 10 different clinicians, MRIs become very helpful. But it's the context of the MRI. An MRI, I'm going to look at my face, take a picture of my face. Now you will see there's scars on my face, and maybe if I had blood over here, that would be a wound. So this is a scar and this is a wound. What's causing the pain? The fresh bleeding one, the wound is causing the pain. The scar isn't. So the MRI shows the picture of all of the wounds and all of the scars. It's not that the MRI is unrelated to pain. No, the assessment gives it context to show what is a wound and what is a scar. But again, the radiologists don't know how to read that because they never saw the patient. But the clinician who has done the assessment and then says, I don't want to see the MR report, I want to see the MR. That's what we insist on. They have to bring their MRs, and now we see, don't worry about that. That's an old wound. That's an old scar of 30 years ago. That's not causing your pain, but that is. And now it becomes very helpful. So Brian Carroll, this beast who picks up 550 kilos off the ground, he came to me with an MR that looked like this, a massive split in the sacrum front to back. There, when I did it to a cadaver, you can see the massive fracture. The MR is very helpful in showing that. And you can see the bulging and the fractures up into L5 and even L4. But I will say, after 3 years of therapy and mechanostimulation, his MRI looked almost, well, you wouldn't be worried if you saw that MRI. You'd be terribly worried if you saw that one. But just to show that the MRI, when you get the mechanostimulation right, it's complicated, it's not easy, and not very many clinicians are skilled enough to do it. But you can create tissue adaptation through appropriate mechanostimulation. But anyway, so the answer is, like everything else, it depends, and sometimes it solves the problem. I think of one patient who came and she was a puzzle. Her clinical pattern didn't fit. I would create stress in her sciatic nerve and it created femoral root symptoms. And then I would create stress on a femoral nerve root and it would create a sciatic symptom. And I couldn't figure this out. How can this possibly be? Until we looked at the MRI. She had a defect where the femoral root was coming out of the sciatic foramen at L4. How would I have known that? So when the pattern doesn't fit, the MRI becomes very important, but you need to be very skilled in assessment and in reading them.
Yeah. I'm intrigued what's happening during this those 2-3 hours of assessment with patients, because it's a long time for patients.
Yes.
Often they are in a lot of pain. And so can you, in a nutshell, explain what happens and the steps that you take to assess the patients in pain?
Well, the challenge is to do it in a nutshell, because every assessment is different. The assessment is a living process. The assessment for one person, would you assess a 75-year-old woman with pain doing just light duties the same as you would a middle prop in rugby who's 24 years old? Of course you wouldn't. You know, you'd have to get out big weights and that kind of thing. So all I can do is give you a general philosophy, and the first one begins with the interview. So I watch them come through the door. I look at their face. When I was a young professor, there was another professor at our university who was an expert at cataloging pain by facial expressions. And if you can't see the pain in someone's eyes and the tension in their face and in their neck and in their knees, you can't read people. And I would say, go get another profession. You're not suited for being a master in the back pain area. You have to be able to read people. So we're reading people very well when we start the interview. We watch how they take their shoes off. We watch how they sit. We try and understand what they perceive as causing their pain and making it worse. We're asking them the character of the pain. Is it worse when you first get out of bed, or does it ramp up through the day? Doing the big three, does that take your pain down for an hour or so? Looking together with patterns, we're looking at their social habits, the impediments as to why they've failed in the past. And then we come down to the assessment room here at BackFit Pro, and then we do very specific pain provocation tests that involve motions, postures, and loads, and then we go for specific tissues. We stress the SI joints, various nerve roots, various anatomical chains. For example, as I said, that tightens the psoas and that releases it. We need to know. Now, does that matter for everybody? Of course not, but it might matter for some. We might have someone with raging sciatica. Do that. Glide the shoulder up, and the sciatica disappears. What's going on? You pulled the whole neural tract up. And again, again, normal clinicians, they don't even know what they don't know, so they don't know what I'm talking about. But when they study at this level, they will see the assessment. You can just keep going and peeling the onion and finding out the real mechanism of why this person has pain. Then, of course, we have to create the antidote. So if this is the mechanism of your pain, let's see if we can teach you life hacks around the pain. Let's get dressed in the morning. Let's go shopping. Let's pick up your child. Let's all of these things that are triggering pain and figuring it out. And then we have to create a program. So if they're an athlete who, like Brian Carroll, he wanted to come back and set a world record with a massive spine fracture. So that took a 3-year program to lay it out. Now, of course, that took multiple visits. I get that. But anyway, there's a little, you wanted a nutshell view of the assessment. There it is. Now, somewhere in there, we might look at medical imaging, which if I turn that, you can see there's a screen where I might watch, say we had an athlete who has played their sport for 20 years. 20 years ago, it wasn't digital MRI, it was films. So you'll see in the corner an old film reader. Then we read the digital MRIs, and then I watch them play their sport with them, and we figure out the program a little bit of what they're going to do. So there's 3 hours. Now you did say, what about the person who's in a lot of pain? They can't stand the 3-hour assessment. So that's when we take a lot of breaks, we stage it, we do a little bit, they sit down. There's a box of tissues over here because I know the tears are going to flow. So those, we're ready for that. We know it's normal, and we'll take lots of breaks. And but people fly from around the world to come here. We can't do assessments over weeks and weeks. We have to get to the point. Some people bring their whole medical staff. If you are the president of a country or a royal family member, you come with your own personal medical team. If you are a $70 million a year golfer, you come with your whole medical team. And that we'll set aside a full day with. So do you see how, a 3-hour exam might be 8 hours actually?
Oh gosh. Um, we're coming to an end slowly, to an end of our interview, Stu. But I find it really exciting, you know, the concept and the assessment and your method. And obviously, I'd love to find out more about it and learn. But I understand there will be other therapists equally interested in your method. So how can we find out more, and how can we start learning those skills in assessment of patients?
Right, I understand. So if you go to our website, which is backfitpro.com, you will see podcasts and different things that I've written, but there's also our textbooks. So if you're a clinician, the starting textbook with the science in it is low back disorders. If you're a member of the lay public and you just want to do a self-assessment on yourself, 9 tests, is it as good as a full assessment with a clinician? No. Is it better than you will get from most clinicians? Yes. So you guide yourself through a self-assessment, and then it shows you what to do and not do. And then if you are a person who aspires to gain back some athletic potential, then we write out those approaches in Ultimate Back Fitness and Performance. But if you're a strength athlete, then I would say read Gift of Injury. And I know you want to translate some of this or subtitle it for Polish. We do have Back Mechanic already in Polish. And it's in 16 languages or something like that. And Ultimate Back Fitness is almost ready for the Polish market. But a lot of clinicians would like the courses. So as you know, we were going to do a course, and I believe you were coming in November to Canada. With the virus situation, those have been canceled. So I've put my lectures online. And they are about to go on the website. So those who would like to hear those lectures and courses, the courses, the first one is the foundational course. It's 20 hours long. And then the next course is just the assessment. It's 16 hours long. And then the enhancing performance is a full day. I think it's about 9 hours. But we'll have the first and second one up within a week or two.
Will there be any sort of face-to-face element to the training?
Not at this stage. But we're still working that out logistically. What we would like is the hands-on. There's no substitute. You can't learn online how hard and how to feel and do whatever it is you're going to do. And every single client is a bit different. So you never treat everyone the same, and that's really the McGill method. Assess and figure out what is going to be best for that person. So that we're going to do live, and I've set up centers around the world. There will be one in Canada, one in the US, there will be one in the UK, and probably one in Europe. So people will just travel to those, and our instructors will be there. And usually I Skype in, just like we're doing today, and I can do a Q&A with them that way. But I think that's the most sensible way, where we don't compromise the science and the skill development, but we also need to figure out a way to get that done in this new reality that we're all living in.
Stu, thank you very much for your time again, and it's been a huge pleasure to speak to you, and it's been fantastic. So thank you very much.
Well, thank you, Merrick. Your questions are really insightful, and that shows me where you're coming from with your work. So good luck with all of you, and thank you so much for supporting what we do and helping to get the word out there a little bit as well. Thank you very much.
Thank you. Bye.
Bye-bye.